Welcome to the session on the pathogenesis of tuberculosis. I am Subhash Babu, the Scientific Director of the India ISA program, and we're going to be discussing pathogenesis of tuberculosis because of its importance in understanding natural history as well as the progression of TB infection and disease. Infection with Mycobacterium tuberculosis typically results in a range of clinical manifestations in humans. Most infections manifest as clinically asymptomatic, contained state called latent TB infection or LTBI. It's only in a smaller subset of infected people that present with symptomatic active TB. Thus, there is a spectrum of host outcomes with varying symptoms, microbiology, immune responses, and pathology within this binary state. So, when we look at the natural history of TB, transmission typically begins with an untreated smear-positive pulmonary TB case. This individual can infect up to 10 to 14 individuals per year. These individuals typically are able to contain the infection and belong to the latent tuberculosis group. They are thought to comprise about 2 billion people worldwide. Only about 5 to 10% of latent TB individuals go on to subsequently undergo reactivation or progression from latent infection to active disease, and these are the ones who go on to develop symptomatic active tuberculosis. And it is estimated that there are about 10.4 million new cases of active tuberculosis each year, with a concomitant death rate of about 1.4 million per year. So, in examining the spectrum of tuberculosis, exposure to M.tb can result in elimination of pathogen due to innate or acquired immune responses. Individuals who eliminate infection either via innate immune responses or by acquired immune responses without T-cell priming or memory usually have negative tuberculin skin tests or negative interferon gamma release assay, also known as IGRA. If the pathogen is not eliminated, bacteria persist in a quiescent or latent state that can be detected as a positive TST or a positive IGRA. Patients with subclinical TB might not report symptoms but may be culture positive, but generally are smear negative due to low bacillary loads. Patients with active TB disease experience symptoms, and diagnosis can usually be confirmed with sputum smear, culture, and molecular tests. Patients with active TB might sometimes be negative on TST or IGRA because of immune suppression caused by the disease itself or by comorbid conditions such as HIV infection or malnutrition. So the spectrum of TB from M.tb infection to disease is basically summarized here on this slide. Infection can be eliminated with an innate immune response, which typically results in a negative TST, negative IGRA, negative culture and sputum smear. These people are not infectious, do not have any symptoms, and do not require any treatment. If infection is eliminated with an acquired immune response, you have a positive TST, positive IGRA, negative culture and sputum smear. They are not infectious, do not have any symptoms, and do not require any treatment as well. When the infection actually is not eliminated, you go on to develop latent TB, wherein the bacilli are contained within the granuloma, and these people typically have a positive TST, positive IGRA, negative culture and sputum smear, are not infectious, are not symptomatic, and may or may not require preventive therapy. The next stage of progression is the subclinical disease, wherein the TST and IGRA are positive. The culture can be intermittently positive. Sputum smear is usually negative. These people are sporadically infectious. They do have mild or no symptoms and do require multi-drug therapy. And finally, in terms of the full-blown active TB disease, they usually manifest as TST or IGRA positive, have positive culture, positive or negative sputum smear, are definitely infectious, have mild to severe symptoms, and absolutely require multi-drug therapy. We will now take a step back and look at the basic principles behind the innate and adaptive immune system in order to better understand the relationship with TB infection and disease. As most of you already know, the innate immune system is comprised of different cell types, including the dendritic cell, the macrophage, the natural killer cell, granulocytes such as eosinophils, neutrophils, and basophils, as well as mast cells. The adaptive immune system is basically composed of two major cell types: the B cells, which produce antibodies and form the main component of humoral immunity, and the T cells, which come in two flavors, CD4 positive T cells and CD8 positive T cells, and which basically comprise the main component of the cell-mediated immune response. In addition, there are other cell types such as the gamma delta T cell, the innate lymphoid cell, and the natural killer T cell, which play a bridge role between the innate and adaptive immune systems. Looking at the principal mechanisms that underlie innate and adaptive immunity, innate immunity is typically comprised of epithelial barriers which help in preventing entry of microbes into the host. Phagocytes are one of the major components of the innate immune response because of their ability to engulf and destroy pathogens. The complement system is another major component of the innate immunity due to its propensity to seek out and destroy infecting organisms. And finally, natural killer cells, as their name suggests, can kill infected cells and also form an important component of the innate immune response. In terms of adaptive immunity, B lymphocytes, upon encounter with antigen, can expand and differentiate and lead to plasma cells, which then produce antibodies, which are the hallmark of the humoral immune response. While T lymphocytes, upon encounter with antigen, can expand and differentiate and form effector T cells, which then mediate the cell-mediated immune response. So this slide basically summarizes the principal functions of the cells of the innate immune response. Monocytes and macrophages are typically involved in phagocytosis, T cell activation, inflammation, as well as tissue repair. Neutrophils are involved in phagocytosis and inflammation. Natural killer cells are important in killing of infected or tumor cells. Dendritic cells are involved in the activation of naive T cells as well as in phagocytosis. Mast cells are important for inflammation, while eosinophils are considered important for defense against parasites. So in terms of the innate immune responses in TB infection, Mycobacterium tuberculosis spreads by airborne droplet nuclei, which can then be inhaled into the airways and alveoli of a new host. The early host response to infection is a typical influx of phagocytic cells, including primary resident alveolar macrophages and recruited neutrophils. Following establishment of infection in the airways and the lung parenchyma, the bacilli are believed to be phagocytosed by alveolar macrophages and are subsequently taken up by neutrophils and dendritic cells. Macrophages and neutrophils, as I mentioned, constitute the first line of defense that function in the early immune response. After infection of the host, these macrophages and neutrophils and the context of their activation can influence subsequent immune responses towards either potential clearance or containment of pathogen, which results in a persistent latent infection, or the inability to contain the pathogen, which results in the development of active disease. So this interaction between the innate and immune response and M.tb is summarized on this slide, wherein if we look at latent infection, upon entry of the bacilli into the lungs, you have the influx of alveolar macrophages, monocytes and dendritic cells. You have the subsequent influx of a variety of other cell types. This basically results in the formation of a solid granuloma. In terms of active disease, this ability to form the solid granuloma fails. You have necrotic cell death within the granulomatous lesion, as well as extrusion of both intracellular and extracellular bacilli, which then subsequently spreads to the other parts of the lung as well as to the draining lymph nodes. So this brings us to the granulomatous reaction and the importance of the granuloma in TB infection and disease. Human TB granulomas are the classic hallmarks of TB infection and disease and are composed of a central mass of infected macrophages, stimulated macrophages that have differentiated into multinucleated giant cells or epithelioid cells, foamy macrophages loaded with lipid droplets, recruited monocytes, and neutrophils. Surrounding this inner accumulation of cells are lymphocytes, largely CD4 positive T cells, but also CD8 positive T cells, B cells, and fibroblasts, which create a peripheral fibrotic capsule. And one of the classical features of human TB granulomas is the presence of a necrotic caseous core that is thought to be secondary to cell lysis and that results in a central hypoxic hostile environment. Shown here is a histological picture of a typical caseating granuloma, and what we see here in pink is the central caseating core surrounded by the purple staining lymphocytes, epithelioid cells, and macrophages. Is also shown here as a different histological picture of a caseating granuloma, and again you can very clearly see the caseous central core surrounded by lymphocytes and epithelioid cells. In contrast, if you look at a non-caseating granuloma, you see that there is actually a central solid core which is composed of different cells, including macrophages and lymphocytes, and this is again surrounded by different cell types such as the epithelioid cells, Langhans types, giant cells, etc. So with that, we now move on to the component of adaptive immune responses and their interaction with TB infection and disease. As I mentioned before, adaptive immunity to TB depends on CD4 positive T cells with additional contributions from CD8 positive T cells. Th1 cells are CD4 positive T cells that produce interferon gamma, IL-2, and TNF-alpha, and are the primary effector cells in protective immunity to TB. Th17 cells are CD4 positive T cells that produce IL-17 and play a role in memory responses to TB and might be important in vaccine-mediated protection. And CD8 T cells also contribute to protective immunity by production of cytokines, expression of cytotoxic molecules such as perforin, granulin, and granzymes, which enable these CD8 T cells to lyse infected cells. So moving on to the role of cytokines in either protective or susceptible immune responses to TB, we know that the IL-12 induced production of interferon gamma is the best validated cytokine pathway regulating TB infection. IL-12 is required for the optimal polarization of CD4 T cells into interferon gamma producing Th1 cells, while IL-23 supports the IL-17 response to TB within the lung. TNF has a well-documented role in human resistance to TB and plays an important role in the maintenance of TB granulomas. In terms of the other cytokines that also play a role in TB infection, IL-1 family of cytokines, IL-1 alpha, IL-1 beta, and IL-18 are associated with protective immune responses, while IL-10 is thought to play a detrimental role in TB infection. It does this by causing a delay in the innate inflammatory cytokine production, in the process of myeloid cell recruitment, and also in the subsequent induction of the T cell response. Finally, type 1 interferons, similar to IL-10, are also thought to play a role that is host detrimental by down-modulating protective immune responses in TB. So my final slide basically summarizes the global interaction of the immune response to TB infection and disease. Mycobacterium tuberculosis infected cells typically interact first with dendritic cells, which are the important initiators of innate or adaptive immune responses. These dendritic cells then activate both CD4 as well as CD8 positive T cells. In terms of the CD4 T cell arm of the immune responses, we know that the CD4 T cells differentiate into Th1 cells, into Th17 cells, as well as into multifunctional Th1 cells. So all these components of the CD4 T cell arm, as well as the ability of CD8 T cells to produce cytokines or to lyse target cells, all basically result in a protective immune response with the formation of a solid granuloma and the establishment of latent infection. In contrast, when any of the arms of these immune responses break down, and I'm just giving you an example of a few, for example, the induction of a Th2 response or the induction of a regulated T cell response, either of which can suppress these immune protective responses, or if the Th1 and CD8 T cells undergo exhaustion, which can also suppress the protective responses, you end up with a caseous granuloma and active disease. So with this, we come to the conclusion of the first session on the pathogenesis of tuberculosis. Thank you very much.